Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hi, my name is Chan Chia. I'm a haematologist at Sir Charles Gairdner Hospital in Perth, Australia. Welcome to this Medscape Oncology Clinical Trials in CLL and Mantle Cell Lymphoma Expert In-Depth Analysis. I'm joined today by my colleagues and faculty, Professor Nirav Shah from the Medical College of Wisconsin and Professor Jennifer Woyak from the Ohio State University Comprehensive Cancer Center in Ohio. In this activity, the three of us will present 4 phase 3 clinical trials in CLL and mantle cell lymphoma, where we'll not only discuss the results of the studies, but also go into a bit more detail in study design and the practice implications arising from this. The key things that we think about when we're analysing these trial results are how the patients included are comparable to our patient population that we see in the clinic, whether these results are immediately practice changing or maybe influencing how future trials are delivered, and whether the new drugs or the new technologies which are used in the studies are able to be accessed in our current settings. And that will, of course, vary depending on where you are practicing. So just to give you a bit of an overview, we're going to cover 4 studies, 2 in CLL and 2 in mantle cell lymphoma. The 2 CLL studies will be covered by Jennifer, and the first is the Bruin CLL 321 study, which was a randomized phase 3 study of the non-covalent BTK inhibitor pirtobrutinib versus investigator's choice of idelalisib rituximab or bendamustine rituximab in patients with covalent BTK exposed CLL. So really the phase 3 follow-on from the Bruin study. The Amplify study is the second study which we'll be looking at, which is fixed duration acalabrutinib, venetoclax with or without inotuzumab in patients with treatment-naive CLL. The 2 mantle cell lymphoma studies which we'll be interrogating will be, first, Nirav will cover the late-breaking abstract, EA4151, which was a ECOG-ACRIN cooperative group study in which patients with transplant-eligible mantle cell lymphoma receiving any induction regimen underwent MRD analysis, and then were essentially, if they achieved a PET-CR and were MRD negative, were randomized to either transplant or no transplant. Finally, I will cover the 4-year update of the Triangle study, which was a 3-arm randomized study conducted by the European Mantle Cell Lymphoma Network in younger fit patients with mantle cell lymphoma, testing 3 approaches to treat these patients with or without transplant, with or without ibrutinib in various combinations. So without further ado, let's go on and listen to Jennifer, who's going to be presenting the Bruin 321 and phase 3 Amplify studies.
Hello, and welcome to Chapter 2. My name is Jennifer Woyak. I'm a professor of medicine in the Division of Hematology at The Ohio State University. Today we're going to talk about the Phase 3 CLL 321 trial. The Bruin CLL 321 study is a randomized Phase 3 trial of pirtobrutinib versus idelalisib plus rituximab or bendamustine plus rituximab in BTK inhibitor pretreated chronic lymphocytic leukemia or small lymphocytic lymphoma. This initial data was presented as an oral abstract at the American Society of Hematology meeting in 2024. A little bit of background on this study. We know that patients who are treated with a covalent BTK inhibitor and progress on treatment have relatively poor outcomes with a short time to subsequent treatment progression, and a relatively limited overall survival. This post-covalent BTK inhibitor treatment setting represents an increasing need in clinical practice, as BTK inhibitors are used often in the first line or in the second line of therapy after a fixed duration regimen. Pirtobrutinib is a highly selective non-covalent BTK inhibitor that was designed to work when covalent BTK inhibitors stop working. This drug was initially tested in the Bruin phase 1-2 study and showed a preliminary efficacy and safety of pirtobrutinib in a highly refractory patient population. This trial led to accelerated approval by the US FDA. The Bruin 321 study is the first prospective randomized phase 3 study conducted exclusively in a covalent BTK inhibitor pretreated CLL patient population. The study is designed as a typical phase 3 registration trial with a head-to-head comparison of pirtobrutinib monotherapy versus standard of care. Primary study population are CLL patients who were previously treated with a covalent BTK inhibitor. There was no limit on prior lines of therapy. Patients were stratified according to the presence or absence of deletion 17p and whether they had received prior venetoclax. Patients were then randomized 1-to-1 to receive either pirtobrutinib given continuously or investigators' choice of idelalisib plus rituximab, where idelalisib was continued continuously, or bendamustine plus rituximab for 6 cycles. The comparator arm here, of course, is not perfect. In the setting of dual refractory CLL, which includes many of the patients considered for this trial, there really is no uniform standard of care. I think this comparator was chosen because a true investigator's choice would likely be too heterogeneous to compare to the investigative arm, but limiting it to just one therapy would be unappealing for patients and investigators. The study does include a crossover at disease progression, which provides equipoise in the setting of a relatively ineffective comparator. The primary endpoint here is progression-free survival as assessed by the Independent Review Committee. Secondary endpoints include PFS assessed by investigator, event-free survival, time to next treatment, overall survival, and safety. And of note, with a study that has the crossover, overall survival is not expected to be positive. The primary analysis for progression-free survival as assessed by the IRC was conducted in August 2023. This is an event-driven analysis, so when a pre-specified number of events was reached, the PFS would be analyzed. For the key secondary endpoint of overall survival, the analysis was triggered in August 2024 after 70 events had been reached. Here's the consort diagram where you can see that 238 patients were initially randomized to the 2 arms. A few patients in each arm did not receive any therapy, and the remainder then were treated. Specifically in the pirtobrutinib arm, 39.7% of patients continue on therapy, and the remainder 60% discontinued for a variety of reasons, primarily progressive disease or adverse events. Looking at the patient characteristics at baseline, they are relatively similar between the 2 treatment arms. You can see this is a very high-risk group of patients, with over half having a TP53 abnormality, almost 90% in the total group having IGHV unmutated disease, and 60 to 70% having complex karyotype. There's a median of 3 prior lines of therapy. Of course, everybody had received a prior covalent BTK inhibitor, and about half had received a prior BCL2 inhibitor. Looking at the primary endpoint of IRC-assessed progression-free survival, you can see that pirtobrutinib is indeed superior to the comparator arm, with a median PFS of 14 months for pirtobrutinib compared with 8.7 months for the comparator. Interestingly, time to next treatment or death is much longer for pirtobrutinib than the PFS at 24 months here. The reason for this is because in this study, progression was assessed every 3 months by CT scan. However, for patients who continued to derive clinical benefit, pirtobrutinib could be continued past disease progression. So we can assume from this that in a clinical practice where you're not doing CAT scans every 3 months, that the progression-free survival we're going to see in the real world will probably be more similar to the time to next treatment as seen here. When looking at venetoclax naive versus pretreated patients, we see a longer time to next treatment in those patients who had not previously received venetoclax. It's really unclear whether this has anything at all to do with venetoclax or just an additional line of therapy. Overall survival, as expected, is not different between the 2 arms. And when looking at subgroups based by clinical or genomic risk factors, we see that basically every subgroup favors pirtobrutinib over the comparator arm. Looking at adverse events, We see most of the adverse events look relatively similar between pirtobrutinib and idelalisib rituximab or bendamustine plus rituximab, with a notable difference that adverse events leading to discontinuation were much, much lower on the pirtobrutinib arm. And we can see this a little bit more clearly when we look at an exposure adjusted incidence rate. So the patients were on pirtobrutinib much longer than they were on the comparator arm. So if you actually look at exposure adjusted rate, you can see almost all side effects favor pirtobrutinib, with the exception of infections and specifically pneumonia, as well as anemia. For adverse events of clinical interest, I think the most important thing here is atrial fibrillation was seen at a very low rate. Only 3 patients, and 2 of those 3 patients had a prior history of atrial fibrillation. So some key takeaways from this study. First, pirtobrutinib demonstrated significant efficacy in this population of patients with previous covalent BTK inhibitor exposure, with similar outcomes to what we saw in the phase 1/2 trial. Importantly, time to next treatment is about 2 years, significantly better than the comparator arm, and really better than other options that you would consider for this patient population. Pirtobrutinib was well tolerated with low rates of discontinuation. And I think that this trial shows us that this is indeed a standard of care approach, and you can really consider whether pirtobrutinib for your individual patient should be sequenced either before or after venetoclax therapy. Thank you very much for your attention. Welcome to Chapter 3, where we'll be discussing the Phase 3 Amplify trial. A little background on this study. So this is a Phase 3 trial of fixed-duration acalabrutinib plus venetoclax with or without obinutuzumab versus chemoimmunotherapy for frontline treatment of CLL. This is an interim analysis of the multicenter, open-label, randomized Phase 3 Amplify trial. These data were initially presented as an oral abstract at the American Society of Hematology annual meeting in 2024, and then were published subsequently in the New England Journal of Medicine. This is the first randomized study of a doublet BTK BCL2 inhibitor using a second-generation BTK inhibitor. We know that patients with treatment-naive CLL have several options for their first therapy. They can receive a continuous BTK inhibitor therapy, this would be ibrutinib, acalabrutinib, or zanubrutinib, or they can receive a fixed-duration venetoclax regimen, either venetoclax with obinutuzumab or venetoclax with ibrutinib. Though not recommended for most patients, some patients still could be considered to receive chemoimmunotherapy in this setting as well. And while fixed-duration venetoclax plus ibrutinib has been shown to result in deep, durable remissions, toxicities, particularly cardiac toxicity, remains a concern, especially in older patients. Acalabrutinib is a highly selective BTK inhibitor with improved safety and tolerability versus ibrutinib. And in the Elevate-TN study, both acalabrutinib and acalabrutinib plus obinutuzumab had superior progression-free survival to chemoimmunotherapy, and here acalabrutinib plus obinutuzumab looked like it had superior progression-free survival to acalabrutinib alone. So in this study, patients were included if they had not previously received therapy and they did not have a 17p deletion or a TP53 mutation. Patients were stratified according to age, IGHV mutational status, RI status, and geographic regions. The patients would then randomize 1:1:1 to receive acalabrutinib plus venetoclax for 14 cycles, acalabrutinib plus venetoclax plus obinutuzumab for 14 cycles, or chemoimmunotherapy for 6 cycles, and this was investigators' choice of FCR or BR. Looking at the baseline characteristics of the 3 arms, they look relatively similar. We can see that this is a young patient population with a median age of 61 in all arms. Most patients had unmutated IGHV, and complex karyotype was seen in about 15% of the patients. 3-year progression-free survival demonstrates superiority of both AV and AVO compared to chemoimmunotherapy. Interestingly, when we look at patients with mutated versus unmutated IGHV, some interesting data emerges. For those patients who have mutated IGHV, 36-month progression-free survival is 86% for AV, 83.6% for AVO, and 79.9% for chemoimmunotherapy. So pretty similar between AV and AVO. However, in the unmutated group, 3-year PFS drops to 68.9% for AV, but stays at 82.8% for ABO, suggesting that patients with unmutated IGHV might derive the most benefit from this triplet regimen. The study was performed during the COVID pandemic, and we see quite a bit of confounding due to COVID-19 in this trial. Deaths due to COVID-19 occurred in 3.4% of the AV treated population, but 8.7% of the AVO population and 7.2% of the chemoimmunotherapy population. This could reflect the use of the anti-CD20 monoclonal antibody in these two arms. Unfortunately, with the competing risk of COVID, it's difficult to know whether this increased death rate is an isolated phenomenon just because of the pandemic, or whether there would be higher infectious-related deaths even in the absence of COVID-19. When PFS was censored for COVID-19 related deaths, the 3-year progression-free survival was 91.5% for ABO, 78.8% for AV, and 72% for chemoimmunotherapy. Undetectable minimal residual disease rates are shown here, and interestingly, the rates of UMRD with AV are quite a bit lower than with ABO. When looking just at patients with undetectable MRD at the end of therapy, we see a similar progression-free survival between AV and ABO, suggesting that the attainment of UMRD with AV is important in deriving long-term benefit. Overall survival of AV is superior to chemoimmunotherapy, but not ABO due to the effects of the COVID-19 deaths. When censoring for COVID, there is an improvement of survival for both AV and ABO compared with chemoimmunotherapy. When looking at global safety, serious adverse events leading to death, or leading to treatment discontinuation are all highest for ABO. Looking at specific adverse events, we have already discussed the high rates of COVID-19 across the arms. We see that neutropenia is a little higher in ABO and chemoimmunotherapy than AV, and febrile neutropenia is the highest in the chemoimmunotherapy group. Headache, which is a typical toxicity of acalabrutinib, is seen in both ABO and AV arms. Given the short duration of therapy, we expect that the rates of toxicities associated with BTK and BCL2 inhibitors will be lower than what's seen in continuous therapy trials. Importantly, atrial fibrillation is relatively similar across the arms. However, although the rates are very low, ventricular tachyarrhythmias are only seen in the acalabrutinib-containing arms. Hemorrhage is low across all arms, but numerically a little higher in the ABO arm. Infections of all grade are higher in the 2 acalabrutinib-containing arms, and high-grade infections are the most common with ABO. Secondary cancers at this time point are seen higher frequency in the AV and AVO arms, although there are really low rates across all the arms. So in conclusion, this is a significant study that has already led to NCCN guideline inclusion of AV and ABO and may lead to regulatory approval of one or both of these regimens in frontline CLL. It's clear once again that chemoimmunotherapy is not as effective as regimens with targeted therapy in CLL. When looking at both AV and ABO, I think we can see that ABO is a little more effective of a regimen, but this is counterbalanced by a higher rate of serious adverse events, including death, meaning we have to carefully select patients for this triplet regimen. When we look at outcomes across genomic risk groups, patients with unmutated IGHV seem to derive the most benefit from the highly effective ABO regimen. One question that still exists is how these regimens compare with venetoclax obinutuzumab, and it's really not clear at this time, but hopefully ongoing trials will help to elucidate this. However, this is a very exciting study, should lead to regulatory approval of a new all-oral and possibly the first triplet regimen in CLL. Thank you very much for your attention, and please join us for the next chapter.
Hi, my name is Nirav Shah. I'm an associate professor from the Medical College of Wisconsin, and I'm here with Medscape Oncology to discuss a late-breaking abstract from ASH 2024 discussing the results of the Phase 3 ECOG-ACRIN 4151 clinical trial. The title of this abstract was Lack of Benefit of Autologous Hematopoietic Cell Transplantation in Mantle Cell Lymphoma Patients in First Complete Remission. With undetectable minimal residual disease, initial reports from the ECOG-ACRIN 4151 Phase 3 randomized clinical trial. To give some background, mantle cell lymphoma is a B-cell non-Hodgkin lymphoma where autologous transplant is often considered a treatment modality as an upfront consolidation for those patients in first response. This is based on data going back to 2005, demonstrating benefit in patients who received a consolidative autologous transplant. However, recent studies have questioned the benefit, and the Triangle study, which was a large study testing the role of autologous transplant in the era of BTK inhibitors, did not demonstrate significant benefit of this procedure if you gave patients ibrutinib as part of maintenance and induction therapy. This is a U.S. trial looking at the role of autologous transplants in patients who achieve first complete remission and are MRD negative, which is sensitivity of 1 to 10 to the minus 6, which is also known as undetectable MRD6. This allowed young patients who are between the ages of 18 and 70 and in first remission who were eligible. And any rituximab induction was allowed, including those incorporating BTK inhibitors. This is a study design, and I'd like to take just a second to describe this because it's an important part. This study had many arms, but a key feature was being able to identify a clonal marker to track in patients, which was then used to test MRD negativity. The primary outcome was really among those patients who were MRD negative and in a complete remission, who were then randomized to either getting an auto transplant plus rituximab maintenance or getting rituximab maintenance alone. There were two other arms known as Arm C and Arm D. Arm C were patients who were not in a complete remission or were MRD positive, and in that group, autologous transplant was recommended as part of the clinical trial. And then there were those patients that were MRD indeterminate who also were recommended to get autologous transplant and rituximab maintenance. So it's always important when you analyze a study to know what is that primary outcome. This is a statistical plan and monitoring. They assumed a 6-year overall survival of 76% and wanted to detect a 10% improvement with autologous transplant to 86% at 6 years. And so the study had 80% power to detect this difference. And again, this was based on the study sample size was based on the primary outcome, looking at overall survival in arms A and arms B. We're now sharing interim analysis for harm and futility were performed. And as a result, these data were then released because it was felt that the futility boundary for an overall survival was not going to be reached with a hazard ratio of 0.984. So these are the patient characteristics. If you look here, this is a largely male population, and that's common because mantle cell does have a male predominance. Otherwise, there were no key differences between patients in Arm A and Arm B in terms of other risk stratification. The primary analysis included all randomized patients. However, some patients refused their initial treatment assignment, and so a treat as a side analysis was also performed. And we're going to share overall survival and progression-free survival. The log rank test, which is a common test to look at survival outcomes, was used to compare survival outcomes in this study. So this is the primary outcome here, overall survival of all patients. And you can see here that there was no difference among all randomized patients. So the estimated hazard ratio between Arm A and Arm B was 1.11 and 1.0 and crossed the futility boundary, showing that there was no survival benefit to autologous stem cell transplant in the patients who were MRD negative and in a complete remission. The absolute numbers here show a 3-year overall survival of 82% versus 83% in Arms A and Arms B. Similarly, the progression-free survival in these two arms was also very similar. The 3-year progression-free survival for Arm A and Arm B, these again are the MRD negative complete remission patients who were randomized to autologous stem cell transplant with maintenance or maintenance alone, was again similar at 76% and 77%. Now, this was some stratifications looking at high-risk patients versus low-risk patients, so MIPI-C patients versus MIPI-high patients. Again, there was no difference between Arm A and Arm B, but you can see here that low-risk patients did have better survival than high-risk patients. Similarly, intensive induction versus non-intensive induction. The 3-year overall survival was similar in both Arm A and Arm B between the two arms here, but maybe, again, a little bit of benefit for those patients who got an intensive induction. Now this is looking at Arm C and Arm D. Arm C were the patients that were MRD positive. Arm D were those patients where we did not have a clonal tracker. And you can see here the 3-year overall survival was 82% versus 85%, and the 3-year progression-free survival was 77% versus 73% in arm C and D. Looking at arm C patients who are MRD negative, they did an exploratory analysis that showed that if you converted to MRD negative after the transplant, that those patients did really well, and sort of had um, survival outcomes of 100% versus 63% in those patients who were MRD positive still after transplant. The cause of death is described here for each of the arms. You can see here that the most common cause of death was lymphoma, followed by COVID-19 complications. Of course, these patients are immune compromised. In conclusion, in this initial analysis, looking at the role of autologous transplant for patients who are getting highly effective induction regimens and maintenance, who achieved a first complete remission and MRD6 negativity, there was no survival benefit, either OS benefit or progression-free survival benefit from a consolidative auto transplant. For those patients who remained MRD positive after induction, there might be a benefit, especially among those patients where auto transplant helped them convert to MRD negativity. Further follow-up is indicated to confirm these findings. My key takeaways from this study are simply that these data question the role of autologous transplant for all patients with mantle cell in the modern era. And really, now that we have this large study, we can use end of treatment MRD to guide who may or may not benefit from transplant, and especially considering not doing an autologous transplant in those patients who have an MRD negative complete remission. Thank you for participating in this activity, and I look forward to the next presentation.
So the next mantle cell lymphoma trial is the Triangle study. And the key question addressed by this study was the role of ibrutinib in transplant-eligible patients with mantle cell lymphoma. To refresh your memory about the design of Triangle, the study was called Triangle, by the way, because of the three-arm nature of the study. All patients received chemoimmunotherapy induction with CHOP and DAP, which are standard regimens used from the prior study. One arm was the standard of care, which was the top, with transplant followed by observation. There was one arm, which was one of the experimental arms called arm A plus I, which was the addition of ibrutinib, both with the CHOP in induction and then for fixed duration 2 years maintenance following a transplant. The third arm was the arm I, which involved no transplant but did contain ibrutinib. And rituximab maintenance was, of course, added to all three studies, all three arms following the results of the Lima trial. So really, the rationale for doing this study was to test whether the addition of covalent BTK inhibitor in first-line patients could obviate the need to deliver an autologous transplant. And this is a really important question because transplants are toxic. They result in significant morbidity for patients, risk of death, very high healthcare utilization. And if the outcomes of patients treated with ibrutinib can remove the need to deliver an autologous transplant, it is something which would be immediately practice-changing if you had access to ibrutinib in the first-line setting. So the inclusion criteria are listed on the slide. Basically, this is the young, fit patient population who would be suitable for autologous stem cell transplantation. And the primary endpoint is failure-free survival with a key secondary endpoint of overall survival, and we'll touch on this a bit later. The baseline characteristics of patients were well balanced between the three arms, and you'll note that patients with high biologic risk, such as high MIPI score, were reasonably represented in around 15% of patients across the board. And it was a predominantly male population, as is typical for mantle cell lymphoma, with a median age of 57, indicating this is a younger population. So the primary endpoint of failure-free survival was tested in three ways. There was a test of arm A versus arm I, and that was superiority for failure-free survival. There was a second test of A plus I versus A, and that was also superiority. And finally, the third test, which was A plus I versus I, really this was one of the most interesting questions, which is whether you could drop autologous stem cell transplant. For the first test, futility was confirmed. So the question was, is the standard arm better than the ibrutinib-containing arm with no transplant? And that this hypothesis was rejected, and this was confirmed with 4 years of follow-up. In terms of the second test, which was failure-free survival superiority for the transplant plus ibrutinib arm versus the standard arm, this was accepted, and clearly the addition of ibrutinib did improve outcomes with a significant and clinically meaningful increase in failure-free survival benefit. The absolute difference here was 12% at 4 years, 82 versus 70%. The third test was the superiority of the transplant plus ibrutinib arm versus the ibrutinib arm, and this is, I think, one of the most interesting analyses. And you can see here that superiority cannot be accepted with these curves. I think this is quite practice changing, because the addition of the autologous stem cell transplant overall added no benefit in terms of disease control. And if we plot all three arms on the same curve, you can see that the two arms which contain ibrutinib, the green and the grey curve, are tracking together and significantly superior to the blue curve, which was the non-ibrutinib containing arm. The transplant made no difference. So nice to see these data with longer follow-up to underscore the benefit of the addition of the covalent BTK inhibitor. And in contrast to perhaps studies in transplant-ineligible patient populations such as SHINE and ECHO, I think that these data are really compelling and practice-changing if you have access to covalent BTK in first line, because you have the ability to remove a toxic and costly treatment, which is autologous transplant. So in terms of the subgroups, and we're looking here at the A plus I versus the I arm, there was no clear effect across the various high-risk subgroups analysed, with the potential exception of the patients with blastoid disease or high p53 expression, but the numbers are small and not powered for the subgroup analyses here. But it did not seem that there was a subgroup of patients who clearly benefited from transplant if you received ibrutinib in the first-line setting. And in terms of toxicity, the key thing here is that the patients who received the autologous transplant had substantially higher toxicity than the arm that did not. And during the induction, the addition of ibrutinib did slightly increase hematologic toxicity. You can see 73 versus 78%. Slight increase in infections and metabolic disorders. So there was a small toxicity price to pay from the additional efficacy. During the maintenance phase, you can see that the addition of ibrutinib, which is both the green and the yellow bars here, did increase hematologic and infectious toxicity during maintenance, because the comparator here was really no maintenance, and rituximab was used equally across all arms. So again, there was a cost in terms of toxicity, but I think when I show you that the next curve, which is overall survival, you may feel that the toxicity cost was worth it, because here for the first time, and to me, one of the most meaningful updates, and the reason this was an oral presentation for this study, is that with 4 years of follow-up now, not corrected for interim analyses, there was a significant benefit in terms of overall survival for both ibrutinib-containing arms, and that's the green A plus I arm and the grey ibrutinib with no transplant arm, now both with a clear benefit in terms of overall survival. You can see the p-values listed here, highly significant, and to me this is practice changing. So if you can use ibrutinib, you don't need transplant, and you will have superior overall survival. And there does not appear to be any gap between the grey and green curves, indicating that for most patients, that there does not appear to be any additional benefit in terms of survival for the delivery of autologous transplantation. So now we confirmed that the ibrutinib-containing arms have superior failure-free survival. We now also see superior overall survival, and we see clearly substantially better toxicity in the non-transplant containing arm, which was ibrutinib alone. On the basis of this, it can be a strong case can be made for the triangle I regimen, which is R-CHOP plus ibrutinib, DAP, no transplant, fixed duration 2 years ibrutinib maintenance as a new standard of care for a transplant-eligible population. And really, I think this now changes the whole way that we think about mantle cell lymphoma, how we split patients up into subgroups, because if you can give ibrutinib in this setting, or as we saw with the EA4151 study, if you're PET-CR and MRD negative, then there does not appear to be a role for transplant anymore. I think the role for transplant is rapidly diminishing. I think that patients with mantle cell lymphoma now can be thought of as, are you fit for triangle? Are you fit for triangle regimen? Can you access the first-line BTK inhibitor? And if you can, then clearly this is the treatment of choice and is superior to similar regimens to what most of us were using prior to the presentation of these data and the results of this study. I think that these two studies side by side are a really nice counterpoint, because they are really interesting illustrations of how both sensitive MRD detection can be used to identify a group of patients who do not require transplant, and similarly, the introduction of a novel therapy as fixed duration has allowed the omission of autologous stem cell transplants and triangle design, both really complementary data sets in a way, and potentially going to shape the way that future studies are designed as well. And it really, if you think about the results of these two studies, will continue to accelerate the incorporation of first-line BTK inhibitors into various combinations in the treatment of patients with mantle cell lymphoma, and it will also accelerate the use of MRD-guided escalation, de-escalation strategies in this disease as well. So I hope you've enjoyed the in-depth analysis from my colleagues on these 4 trials: Bruin CLL-321, Amplify, EA4151, and Triangle. Thank you for participating in this activity, and please continue to answer the questions that follow.